Good evening, everyone.
Hi, good evening,
Good evening,
Dr.
Tanvi.
Tanvi.
Yes,
Good
so,
evening, Hiren. Good
Good
evening,
evening, sir.
Pankaj.
Good evening, sir.
Mr. Gaurav, please make Hiren Sodha sir co-host, Dr. Gaurang Shah sir co-host, and when
Tanvi,
Dr.
now you are a host.
Pankaj
You can make
Maheshwari sir also co-host.
Tanvi, you are a host. You can make all of us co-host.
Uh, okay, I am okay. I will do that. Okay, I know. I'd just like to inform today's students who are going to participate. Dr. Solairaj from Gangaram, Dr. Mukkani Velan from Apollo, Dr. Ashay Patil from JJ, Dr. Hamid from Global, Dr. H.S. Rathod from Army Hospital, and Dr. Prashant Hudge from AIG Hospital, Hyderabad. Each student is going to be given 2 students per case, and the cases have already been allotted. Dr. Brijesh will just call out the name of the 2 students who are presenting this first case, and only those 2 students, please unmute yourself. Rest of everybody, please keep yourselves muted so that there is no disturbance. Brijesh, what is first case?
Yes, the Asif Patil and Dr. Hamid will be presenting.
Yes, so PUJO with Dr. Ashay Patil and Dr. Hamid.
We are going to go according to the like a exam format. So Brijesh is not going to present. The students who are answering, like in exam, they are going to present the case up to the examination, and then we will ask them questions, and whatever investigation or surgery or whatever the management they want to do, they will uh, answer, and we will discuss about that. Please make it you know very quick and proper so that we can finish each case in 30 minutes like in exam. Maximum, if the discussion is very interesting, then we may go ahead for another 5 or 10 minutes, but we are not going to cover the full subject in this case study. Okay? Fine. I think, Pankaj bhai, can we go ahead?
Surely.
Yeah. Dr. Gite is traveling, but he said that he will join in another 10-15 minutes.
Perfect.
Okay. Fine. So who is going to present now this case?
Hi, sir. This is Dr. Ashay Patil from JJ Hospital. Uh,
Yeah.
so this is
And
case
Ashay,
one.
who is going to be along with you in answering the questions?
Me, sir, Dr. Hamid.
Okay. Fine. So Ashay, start presenting.
Yes, sir. Case one. This is a 38-year female presented with a complaint of pain over right flank since 2 months. So, sir, further, I would like to ask about the character of the pain, the onset duration, and the progress, natural history of the pain, and the severity of the pain. I would also like to ask about any other associated symptoms like fever or hematuria and
No, you
lithuria.
have got a full history, na? You just present as in exam. You present the full thing.
Okay, sir.
You have got with you or Brijesh? Brijesh?
Sir, next slide. Patient was relatively asymptomatic before 2 months when she developed pain over the flank region, right flank region. The pain was dull aching in nature, sudden in onset, radiating from loin to groin, and gradually progressing and has increased since the last 15 days. It was associated with nausea and vomiting, and there are no specific aggravating factors, and pain is relieved on taking analgesic. Next. No history of lithuria, no history of hematuria, fever, no history of facial puffiness, exertional breathlessness, lower limb edema, no history of jaundice, headache, or backache, and no history of bleeding disorder, anticoagulant therapy, or blood transfusion. Next. There is no history of hypertension, diabetes, tuberculosis, hypothyroid, or hypothyroidism. There is history of sickle cell anemia. Patient has no allergies, no significant family history, normal obstetric history, and regular and normal menstrual cycles. On personal history, the patient has a mixed diet, normal appetite, regular normal bowel and bladder habits. Sleep is normal, and no history of any addiction. Next, on general examination, the patient is conscious, cooperative, well oriented to time, place, and person. Weight is 60 kilogram. Height is 166 centimeters. The vitals are normal. Pulse is 76 beats per minute. BP is 122 by 80 millimeters of mercury. Carnofsky score is 100. Respiratory rate is 18 per minute. And patient is afebrile with 98% saturation on room air. There is no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. And head to toe and spine examination are grossly normal. Next, on per abdomen examination, the patient was examined in a well-lit room with proper consent in supine position. On inspection, the abdomen is flat with a centrally placed and inverted umbilicus and normal thoracoabdominal respiration. There is no evidence of scar, sinus, or dilated veins. No visible swelling. Right renal angle fullness is visible on inspection, but no visible peristalsis or pulsation, and the hernial sites are clear. Next. On palpation, there is no local rise of temperature, no tenderness. Right kidney is palpable. Hernia orifices show no cough impulse, and spine is normal with no deformity or tenderness. On percussion, the abdomen is tympanic. Renal angle dullness is present, and on auscultation, there is no bruit, and bowel sounds are normal. Next. The other systems examinations is normal, and the on per rectal examination done in Sims position, normal anal tone is there, no evidence of fissure, fistula, or hemorrhage, and no blood on glove. Next. Okay, sir, this is my history and examination of this patient.
So you got a full history and you know the full examination. So what is your clinical diagnosis? There must be
Sir,
some differential diagnosis you must have made in your mind.
yes, sir. In my mind, according to this history and examination, the the patient on history has right flank pain, which is dull aching and associated with nausea and vomiting. So on history, my differentials will be urolithiasis first, then uh, uh, s- uh, PUJO obstruction, and then cystic disease presenting with acute change, and lastly mass. And on further on examination, there is a renal flank fullness and also kidneys palpable. So I would further keep stone disease lower down on the list and uh, keep PUJ obstruction as the first differential, and then cystic disease with acute change, and then urolithiasis.
Okay, fine. But instead of only saying PU junction obstruction, there may be just an obstruction also.
Hydronephrosis.
Hydronephrosis is secondary to any other obstruction, na?
What sir
Yes,
is
sir.
saying is that you should say generally any obstruction and then give the different causes. It can be PU junction obstruction, it can be obstruction due to a calculus, it can be obstruction due to a sloughed out papilla,
Yes, sir.
it can be due to a stricture.
Because patient has got sickle cell anemia also, na? And
Yes, sir.
one more thing is that it can be stricture. Tuberculosis is very common.
Yes, sir. Obstructive urethra.
Yeah. Okay, so now you have said obstructive uropathy. What do you mean by obstructive uropathy? Why I'm
Sir,
asking you? Because the same answer was given with one of our student, and then we read, and then we found out that Campbell, then it says that it is a lower tract obstruction causing upper tract, then it is called obstructive uropathy. Instead of that, it is better to say in exam that it is right-sided
Hydronephrosis.
obstructed system.
It's upper tract.
It is
Yeah.
it's important to use words very carefully, nephropathy and obstructive uropathy. And also, like sir said, just say which side, and just maybe you're suspecting obstruction to the urinary flow, because patient is passing urine from.
Yes, sir.
Okay. Fine. So now what next what?
Sir, next I would like to investigate this patient by doing a complete blood count, a renal function test, serum electrolytes, urine routine microscopy, and ultrasound of the kidney, ureter, and bladder as an extension of my physical examination.
Now you want to do ultrasonography, kidney, ureter, and bladder, or you want to do the full abdomen?
But I would prefer a focused examination of the kidney, ureter, bladder, since the patient is presenting with crying pain, and we have found that on palpation it is the kidney and not
But it
hepatomegaly.
can be anything, na? It can be any mass which is pressing over the ureter, giving rise to obstruction.
You only said
Yes,
mass,
sir.
no? Then why don't you want to see whether if that mass is suppose going into the liver?
Yes, sir.
No?
Might be.
Pankaj bhai,
So,
Yes, sir.
Dr. Pankaj Maheshwari ji, please.
Yeah.
What you think? How they should go ahead in the exam?
Sir, even I would feel that sonography of KUB should be enough, sir. Means with a palpable kidney and a very typical presentation, we are really not looking at anything else. But yes, means idealistically speaking, every sonography should be a complete sonography. Even if we ask for a KUB, the radiologist is supposed to look at every other organ before he comments on kidney, ureter, bladder.
Okay, fine. Rijesh, show him the investigation. Hamid, you are also there.
Yes,
Now
sir.
you tell us everything now, whatever you're seeing, and next what you want to do.
Sir, the sonography images.
Just see all the just see blood report. Show him the blood report. Yeah. So nothing much significant. Okay.
No, yeah, as far it is normal, sir.
Yeah. Okay. Show the sonography. Yeah. Can you read it, Hamid?
Yes, sir. So this is the sonography of whole abdomen. The right kidney is seems to be grossly hydronephrotic with thinned out parenchyma. No parenchyma is visible in this, and yeah, other system seems okay. The liver and the gallbladder, other organs.
and the contralateral kidney seems normal.
The contralateral kidney, yeah, it's normal. Yeah, contralateral kidney seems normal. The bladder images are not this.
So, what's your opinion? What do you want to say?
So it is the right-sided grossly hydronephrotic kidney with thinned out parenchyma. So probably it's a chronic. It's secondary to the chronic obstruction, which may be due to any cause. Either it is a stone or PUJ or the stricture disease. That can be ruled out on further investigations.
Yeah. So what you want?
Since the patient has normal creatinine, I would like to get a CT view, sir, of the patient.
Okay. Brijesh?
So the right kidney, the liver is normal, gallbladder is normal, pancreas appears normal, spleen is grossly enlarged and measures 18 centimeter. Right kidney is enlarged, measures 16 into 8 centimeter, gross hydronephrotic with thinned out parenchyma in mid and lower pole. The renal pelvis is ballooned, measuring 8.6 centimeter in AP dimension. The upper pole cortex measures 10 mm. Left kidney is normal and urinary bladder is empty. No evidence of ascites or abdominal lymphadenopathy.
You said left kidney is normal. What is the normal left kidney size?
So the size and the CMDs and the echogenicity of the kidney on the ultrasound.
So what is the size of a normal kidney?
So 11 by
9 to
6 by 5.
9 by
9 by 12 in the length, 5 to 6 centimeter in the breadth, and anterior posterior 3 to 4 centimeter.
So, means how often do you see a 12 centimeter kidney in your day-to-day practice?
It's more of a 10 centimeter I usually see. It may be some somewhat hypertrophied in response to the contralateral.
Why should it get hypertrophied?
Due to the contralateral that is ballooned up kidney, it seems the parenchyma is thinned out, so it may be the less functioning kidney. That's why.
So you need to read the correct, mention the correct term. So
Okay.
this could be a compensatory hypertrophy.
Yes, sir. Compensatory hypertrophy.
So instead of saying it is normal, I would have said, hey, understand one thing, that don't try to read everything. Like even when the pathology reports were shown, instead of saying normal, mention what are the important things you have noted there. So I would have said hemoglobin low, creatinine normal, rest normal. Here also, instead of talking of spleen, pancreas, are we really interested in looking at that?
No,
So I
sir.
would say right kidney is significantly hydronephrotic with thin cortex. Left kidney shows compensatory hypertrophy, otherwise looks normal.
Okay, sir.
So instead of reading it line by line, convey what you want to say.
Okay, sir.
Now, what is the significance of compensatory hypertrophy?
Amit, sir has asked
Sir,
a question. You can also
yes,
answer.
yes, sir. So according to the patient's body weight and height and the whatever functions two kidney does, that is taken up by the one kidney, and that is maintaining that amount of GFR. So there is the
Sir,
Sir
so
has
the
asked you, what
opposite.
is the importance of compensatory hypertrophy? What is an inference you are getting now?
Yes. So
yes. So
what do you infer when you see
Sir, it is a
that
chronic
why
pathology.
should left kidney, suppose if right kidney, normally if we for discussion sake consider both kidneys to be 50-50,
yes,
ऐसा होता नहीं है, but still if we consider that, if that becomes 35, will you have a compensatory hypertrophy on the other side?
no, sir.
So when there is a compensatory hypertrophy, it means that there is a significant deterioration of the opposite kidney function, and two, that it's a chronic process.
Yes,
In an acute deterioration of renal function, again, you will not see a compensatory hypertrophy.
yes, sir.
So now the moment you say this, you have also indirectly ruled out stone disease as a cause, because with stone disease, with a relatively shorter presentation, you would not often see compensatory hypertrophy.
Yes, sir.
ठीक है, चलिए आगे चलते हैं.
Yes. So now what you want?
A CTI view, sir.
CTI view. Before that, what you will do in this particular case?
I'll I'll ask the creatinine is done for the patient, and I'll ask patient about any allergies to the contrast or any previous procedures, and yeah, prepare the patient for the CTIV and counsel him about the
What is the
procedure.
positive history in this patient?
Sickle cell anemia, sir.
So do you think you want to, before giving contrast, you want to, or as usual, like a normal person only want to do it?
I don't know, sir, about this.
There can be chance of iodinated contrast hypersensitivity for fetal cell anemia patients.
So what do you want to do?
So
I'll like whenever I'm about to take the patient, I'll counsel him about the hydration status pre-procedure and the post-procedure.
Yes. Yes,
And
Akshay. Any suggestion from your side? Yeah, Paras, you can unmute yourself. You want to have any suggestion?
Dr. Hamid, my question is, why do you want a urography?
I was just
sir,
about to ask that.
just
What are you suspecting now?
Sir,
What are you
urography will provide us with anatomy also and the function also. Like
No,
we
no,
can
but
You are
comment
what are
on
you
the
diagnosing
drainage.
suspecting now?
P-junction obstruction. You will
Yeah.
definitely be doing a nuclear scan, which will give you a better functional assessment.
But on CTIU, sir, we can see about any other abnormality outside the KUB system if it can
Like
be a cause of this.
Crossing vessels.
Like
Looking at this sonography, do you think you can salvage this kidney?
no, sir,
why?
And why do you say that?
because the parenchyma is very thinned out, sir. It
No, they have said
and
it is 10
Sir, upper
millimeters.
pole is 10 mm, so we can conserve also.
They have said it's a 10 millimeter cortex. Why should you not be able to salvage it?
but sir, only one pole it is, not the other like the mid pole and the lower pole are very thinned out, sir. And still,
ठीक है, चलिए, granted.
If the same patient was a child, would you have any different approach, or would you
yes,
still
sir.
ask for X-ray?
Then I will directly go with the nuclear scan, sir.
Was CT done?
I would preferably do the ultrasound and then the renogram only, sir.
No. Here in this case, you've asked for the CT. I'm asking, has the CT been done? Ask them for the report.
Okay.
So in exam, they may ask you, when you say that I want to do CT IVP, they may ask you why you want to do it. All these things now, whenever you are asking for any investigation, you should be ready to justify it. Okay?
Yes, sir.
So always remember. So you justify it that whatever answer you want to give, you want to see whether there is a contrast is seen coming to the pelvic LSH system. One, then what is a nephrogram? Second thing, you want to rule out that there is any other, because she has presented at age of 35. You want to rule out any other pathology outside. You justify it. Once you say investigation, you must know how to justify it.
Yes.
Okay?
Yes, sir.
Yeah, fine. Show him. So what, Brijesh, what was done? Just tell him.
So patient was in a regular follow-up with a nephrologist. So she had priorly done a renal scan. So these were the findings. Technetium ECG.
So Akshay,
Yes, sir.
this is what was done. Okay, ICT IVP was not done, and this is what is done. You believe in this, or you want to repeat, or you want to do? Now, one side you are saying that there is a compensatory hypertrophy, correct?
Yes,
Because
sir.
as Dr. Maheshwari said, that means it is a chronic obstruction and the function of opposite kidney has to be very less. Then only then you'll get a compensatory hypertrophy. Now here it is showing that it is almost like quite a good function. So depending on that, you will go ahead and do the surgery. You want to do any other investigation, what you want to do, or you don't want to do anything.
Sir, I would still like to do a contrast CT IVU.
Okay.
IVU urography.
Brijesh, show them. Just show them. Keep it for 2 minutes and then change it.
Yes, sir.
Okay, sorry. So this is the contrast CT IVU urography of with the plain face, and it is showing grossly hydronephrotic right kidney with uh, with parenchymal thinning present, and the opposite contralateral kidney appears normal, and
No. First of all, please ask them
ureter
to
is
show
not
you all the
visualized.
films. Beta, please ask them to show in exam. Say, sir, I like to see all the films, and then comment. See
Then I would
everything
like
now.
to see the next ones.
Brijesh, any other cities there? No, just okay.
Yes, sir. Only this.
Okay, go back to the first one. Okay, now comment everything and means in toto and tell us.
Okay, sir. So this is a contrast CT IV urography, and which shows the right grossly hydronephrotic kidney with uh, with a large extrarenal pelvis, and with preserved uh, upper pole cortex and thinned out mid pole and lower pole cortex, with uh, with no hydroureter, and normal left kidney, and on the delayed films, the left kidney shows normal excretion, while the right kidney shows uptake but uh, no delayed no drainage even on delayed images. And the hydronephrosis seems to be crossing the midline, so we can call it a giant hydronephrosis. That's all.
So now what you want to do?
Where is it crossing the midline?
On this reconstruction second image.
No, that's an oblique image. That's an oblique image.
Okay.
I don't think it is showing crossing of midline. Anyway, that's not important. Go back one image, go back. Now you see, what are the things that you want to convey here? You want to convey that there is no radiopaque density seen, opposite kidney is normal, and right side kidney is significantly hydronephrotic with ballooned renal pelvis, large ballooned renal pelvis, ureter not dilated, and you have covered practically everything. So end with saying that I have confirmed my diagnosis of right PU junction obstruction.
Okay.
Has this really helped you? Means, have you got anything which you did not know?
Sir, from CT, I would come to know about any if any crossing vessel is present.
No. Don't talk theory. In this particular patient, has it helped you in any way?
So even if there is a crossing vessel present now, let's say there is a crossing vessel, how does it make a difference? You were saying that I want to assess the function. And sir also corrected you that normally you would do a renogram. So it is always better to say renogram for function rather than saying CT. Bolo, sir is saying, has it helped you? CT.
Yes,
Sir,
sir, it
it
has.
has helped with anatomical details and for planning surgery.
Okay,
Sir,
what
it
plan?
has. Sorry.
What surgery you're planning now?
Sir, I would like to plan
No, Akshay, first
Akshay,
you
beta,
answer.
did you ask for a renogram? Have you asked for a renogram?
Renogram, they have already shown, Hiren.
Acha, okay,
They have already shown the renogram before CT.
okay.
So renogram is done before the CT.
Yes, the patient came with a renogram and then the CT was done.
See, Dr. Maheshwari has asked you, have you become wiser by doing this investigation? So you just tell him, no, what are the things which you have noticed, which otherwise you would not have got it, if you have anything. Second question is, suppose if you do this CT IVP, after that, will you like to do DTPA renal scan?
already.
So, sir just told you now that you can justify your answer. You said you have become wiser by doing the CT. Justify it now. At least now you know it's such a hydronephrotic kidney. There is such a big pelvis. If you're planning to salvage it, what procedure you can do that you could see, not see on ultrasound? You now know that the ureter is okay. You know the opposite kidney is okay.
Yes, sir.
Exam is all about justification. No, we may
Okay.
confuse you. One
So
examiner
anyway,
may say something.
the repeat DTPA renal scan, EC scan was done. Brijesh, show them.
You could have asked question, why repeat? Because some time has gone by.
So number one, patient had come to urologist now. Earlier he had gone to nephrologist, so he had done only EC scan. Now the same place after 6 months, this is a report because the urologist felt that both the reports are not matching. The function here it is totally different and is a very large kidney, very big hydronephrotic. If he does the surgery, then what are the chances it is not going to reduce in size, and still later on patient may have continuous hydronephrosis.
What protocol they have used for DTPA?
So he repeated this. Now this is a finding.
Sir.
Sir is asking question, Akshay.
Sir,
What protocol?
F0 protocol was used for this EC renogram, in which the radionuclide tracer as well as the diuretic was given at the same time.
So is it okay in such type of patients?
It is the standard protocol.
I know that is standard protocol used commonly all over the India.
Sir is asking this patient.
In this patient, is it okay to go for F0 protocol, considering the large external pelvis?
So Hamid, now you have got whatever the thing is, now there is a discrepancy, but now this is a report. Now what you want to do?
Sir, based on these findings, it is non-salvageable kidney. And sir has asked that what protocol should we use? If we would have used F minus 15, then it would be more informative as compared to F plus 0.
Correct.
When you send a
So-
patient for nuclear scan, what instruction will you give to the patient?
I'll instruct the patient that you should be well hydrated, your bladder should be empty, and the well hydrated and bladder should be empty. And in preferably in children, the children should be catheterized by the feeding tube or whatever. So the bladder will be like empty, so the report wouldn't be fallacious.
So within a period of 6 months, what happened? Suddenly the function goes down.
Sir, that is DTPA renogram, and this is EC
When
renogram.
you compare both the DTPA or EC, whatever they have
No,
done,
I think both are
Both are
EC.
EC.
Both are EC. There is not one DTP and one EC. Because I
so
remember
suddenly in 6 months, what
Ah.
happened to the patient? So which is the correct and which is wrong?
Earlier it showed 174 and 140 EC clearance, and now it is showing,
So-
I think, less
So
than 40.
if it is normal at this age and within 6 months it is dropped down tremendously, so one report should be wrong.
Yes, sir. The earlier one was wrong as on the basis of CT IVU also, because there is no contrast excretion in the system. That is more towards this finding.
And previous showed only mild hydronephrosis, which was inconsistent with the USG and CT.
Okay. So now in this case, you can, always say like that looking at the CT IVP, okay, now this EC scan or renogram is, quite similar to that, and you will like to follow according to this renogram. So now what do you want to do?
Sir, I'll counsel the patient about the procedure and the indication of the surgeries because she is symptomatic, though. So we can proceed with the surgery which can be either in the form of lap robotic or open surgery.
What surgery?
And remove
surgery?
the nephrectomy, simple nephrectomies.
What are the indications for simple nephrectomy?
You agree?
How much is the cortical thickness? What is differential function? What is the GFR? How we have decided it is simple
Ashay,
nephrectomy?
you agree with
Sir,
him?
no, sir, I would like to go for open Anderson-Hines pyeloplasty for this patient. And in view of like preserved cortical thickness and 14% differential function.
So Ashay, I want
In
to
a
ask you
young
3
patient.
questions. I am giving you 3 options. One is to do PCN, wait and watch. Second, to do double J stenting. Again, review and directly go for a surgery. That is as per your advice, we are going to do reconstructive surgery. So out of these 3, you want to still stick to your answer or you want to change anything?
And Akshay,
Sir,
will you
if this
decide
patient,
on Akshay? One more question: will you decide on GFR or will you decide on relative function? You said relative function is 14%.
sir,
बोलो ना. Answer, sir. Question.
yes, sir. If she had come with infection or urosepsis, then I would have gone for DJ stenting, SS, PC, and insertion. But in this case, I would like to do a diagnostic cystoscopy with RGP intra-op followed by pyeloplasty.
Why pyeloplasty?
Okay,
How much
suppose
is the
you are
GFR?
going ahead with the pyeloplasty, what
Sir,
specific,
for if L1
advice or information you will give to this patient? What are the
Sir,
things you will explain?
Sir, I would explain that since this the function of the kidney is quite low, so and about the that we are doing this surgery to preserve whatever function is left, and it will not result in increase but prevent further damage.
What points make
Okay,
you
that
to
is number
decide
one.
to go for
Second,
pyeloplasty?
And second, she might require repeat procedures or a nephrectomy further on, later on.
third,
And I would like to explain the alternative procedures.
no, you always in such a large kidney, and if you are going ahead with the reconstructive surgery, post-operatively patient will get sonography done and it is going to show hydronephrosis. Not only that, even if you do DTPA renal scan, it may not show. It will say a poor drainage. But still, if the patient has got no symptoms, if there is improvement in the little function, okay,
Yes, sir.
then in that case, and even if there is a very poor drainage, it is a
What?
successful surgery.
I
So
would
these
like to
also
ask
you
you
will.
the same
No, no,
question what
no.
Gite sir
My
asked.
simple question is, what
What
factors
are the
make you to go for pyeloplasty?
correct? I was saying the same thing. What makes you think about phyloplasty? How would you decide, or what will you tell the patient? Now you're saying that I will tell the patient that after pyeloplasty you may require repeated procedure nephrectomy. Then sir, why
Sir,
you're doing
she is
pyeloplasty?
first over for intervention. She is symptomatic, and in
No,
view
no,
of
no question. She required intervention. We are not no, we don't have any doubt on in that. What intervention and how you decide that intervention? This is the question.
Pankaj bhai, we are finishing this case, so can you just guide them?
So when you said pyeloplasty, there were they were both the kidneys, right? And you had two renograms. If you see that there is a global reduction in the GFR, and then patient is going to become, dialysis dependent, or there is going to be a CKD, then maybe it still gives you some, hope that you try to save little renal function if the other kidney is also compromised. But here, if the other kidney is good and this is a severely compromised kidney, then what are the factors that you still want to do pyeloplasty? So Gite sir was trying to ask you, what are the factors favoring pyeloplasty? Justify it.
sir, there is still some cortical thickness present, and the
Don't answer like a layman. Some cortical thickness means what? You have done a sonography. Sonography you have already seen. You must have asked for the cortical thickness. You must have remember that. In the GFR, you see, you have to calculate the GFR. You have to calculate the
Yes,
differential
you
fraction.
answer. Whatever,
yes, sir.
see, justify in
10
exam.
mm
Exam
upper
wants to
pole
justify, na?
cortical thickness is present, sir, on your sonography.
7 mm.
You can always say, okay, sir,
10.
in delayed prints, we are able to see, contrast into the pelvic calyces, means in the calyces, and the patient is symptomatic, and the glomerular filtration rate as well as the differential function is equivocal. Not only that, the earlier EC scan was showing probably a good function. So I will like to give chance to this patient. I will explain her everything, and I will explain that she may require a redo surgery in the form of nephrectomy, or maybe sometime pyeloplasty or revision, or again degescenting or something like that. Understood?
Yes, sir.
At the
Actually,
same
how
time, you
much
will
is
say
the
that
GFR
this
in this patient?
hydronephrosis is
Sir,
not going to
sir.
go away, because post-operatively, when we repeat in our protocol about ultrasonography, or when we do the repeat EC scan or DTPA renal scan, it is going to show that there is an obstruction, but function may
Sir.
improve or remain same, and symptomatically, clinically, patient will not have pain, fever, and other problem. So that goes in favor of a successful surgery.
No, sir. Sir, successful.
Okay.
Here the question is not successful
Amit,
surgery. Here,
why you
Gaurang
want
bhai,
to know?
let Gite sir talk. Gaurang bhai.
Gite sir has come. I am
Yes,
searching
yes.
him.
So
Gite sir.
here there is no question of successful surgery. Approximately 40% pyeloplasty, there is improvement in function. Some improves, some deteriorates. Usually, if it is done within, it should be done
Dr.
within
Gite
1 year
has
of
joined.
1 year of the blockage. Now that is the theoretical part. Here, while deciding the intervention,
I think sir has not joined.
अरे सर बात कर रहे हैं सर. गौरंग भाई, डॉक्टर गीते बात कर रहे हैं.
if you have to, when you are deciding the intervention for 5 points, symptomatic, no symptomatic, cortical thickness, upper pole, mid pole, lower pole,
I
on
can't hear him.
sonography as well as on CT scan, then parenchymal uptake, across PUJ drainage, no drainage, then differential function, 15% less more, then GFR, 10 less more. ये सब कंसोलिडेट करके डिसीजन लेना है. तो अभी यहाँ GFR तुम्हारा 25 का 3 से डिवाइड अगर कर दिया तो इसी 25 है आपका, इसी में तो कितना आता? 8.5.
10 के नीचे हो गया ना?
हाँ, 10 के नीचे हो गया. उधर तुम्हारा 15 के आसपास डिफरेंशियल फंक्शन. कॉर्टिकल थिकनेस तुम अभी 7 मिलीमीटर बताया है, बराबर है. तो अभी ये 2 पॉइंट और सिम्टोमेटिक है, तो सर्जरी तो भी इम्पोर्टेंट है, एज ऑफ द पेशेंट भी इम्पोर्टेंट है. ये सब चीजें एक दो तीन चार
जी, I can't see him.
देखना है और उसके हिसाब से डिसीजन बताना है. एग्जाम, इन एग्जाम यू कैन नॉट टेल कि आई विल प्लेस द पेशेंट, I will place the DJ until and otherwise there is indication for the diversion temporary, then only you can tell. Otherwise you have to tell one thing in exam, that is pyeloplasty or nephrectomy, and you have to defend that.
Correct.
You cannot tell I will do a pyeloplasty, later on I will do a nephrectomy. वो patient को कितने बार बोलेंगे फिर?
This is what I was asking you, Akshay, that you are only telling relative function. These are the points that you should have justified. When you said pyeloplasty, if you would have given this kind of summary, then examiner is happy.
So if I am wrong, all seniors can correct me. These are the things one should have taken into consideration.
Absolutely, sir. Absolutely. Absolutely. Including opposite kidney function, age of patient, all these things.
So, Akshay, if we have to again summarize this, the way this should be answered is that I have a young lady with significant hydronephrosis with 10 millimeter cortex showing 15% contribution and symptomatic obstruction. In view of young age and cortical thickness, I would want to give chance for salvage of this kidney, and I would suggest her to get a pyeloplasty done. Okay. The aim of the pyeloplasty is to give her symptomatic relief and maintain whatever function she has. The function may not improve with time.
That you said nicely.
Yes.
Akshay.
So, इस तरह से आपको, the way you answer, you should justify what you are saying.
Absolutely.
At the first consultation, when we are doing pyeloplasty, we don't talk to patient about the need of nephrectomy later on. Nephrectomy is a problem that happens to the patient. Suppose this patient doesn't improve, gets repeated infection, gets repeated obstruction. Later on, you find that the function has gone down dramatically. Only then, what is the possibility of that? Probably less than 5%.
It's a sensitive issue. So you have to
So,
talk very carefully.
At this time, you justify the procedure that you intend to do, and the procedure at this time is pyeloplasty in view of these reasons.
So if I am totally agree with this, sir. If you talk 2 surgeries in a first go, then patient को आपके बारे में confusion हो जाएगा. डॉक्टर confident नहीं है, कौन सा ऑपरेशन करना पता नहीं है. ऐसा
Any other questions or we finish the case over here? Pankaj bhai?
Haji sir, somebody has requested that we should have time for questions. If so, people, if others want to ask any question, we can keep it open for 5 minutes maybe.
Yeah,
Okay.
that's
Yes, sir.
Yeah,
Yes, sir.
okay.
all the others should also participate. So it's a good idea.
Yeah.
Sir, in these cases, like when there is a dilemma of the function, can we put the DJ stent and reassess after some time just to see the
See, never talk
improvement?
of digestant. Now, if you want to really assess the improvement of renal function, if there is a doubtful case where you want to assess the improvement of renal function, it is always to place a nephrostomy so that you can get the output from that kidney, which you can use to calculate the GFR. Further, if you know the contribution output from that kidney, say even if the GFR is low, but that kidney is producing more than 500 ml urine, it is still becomes a salvageable kidney. So if that is a question, whether I want to know whether this is a salvageable kidney or not, PCN is probably better than a digestant.
Totally
But,
agreed.
but
So-
primarily you would advise a PCN only when patient has active infection, not otherwise.
Pyelonephrosis or something like that, sick patient.
Yes.
But sir, these two reports are like so discriminant. The patient might ask that
So
why is
again, the
that?
way to explain why you are still operating with 15% function is that you can also say that DTP urinogram would falsely show low function in presence of obstruction and in presence of large dilated kidney. Both are the reasons when there may be a function in the kidney, but it would show a low function. Further, why was there such a big discrepancy between the two reports is because probably the drawing of the ROI that happens during DTP urinogram, that must not have been correct in view of such a hugely dilated kidney. So if they don't mark the ROI properly, they will do miscalculation in their reporting.
And sir, second thing, as Gite sir mentioned, sir, that we have to like summarize these criteria, but all the criteria are in favor of not for the reconstructive surgery. Then again, we have to like counsel the patient for the pyeloplasty because he's
No,
her gene.
जब आप बात कर रहे हैं, you present it in a way. First, you have decided that you want to do salvage this kidney. Are you with me in this point? Okay, then if you have decided to salvage the kidney, present your points which help you take a decision of salvage of kidney.
Okay.
Okay,
Okay.
sir, I think they're a little bit confused because both were ECs. One was not DTP and one was EC.
No, both
Both
were
the-
easy. I know. Huh.
Yeah.
But I think most likely reason must be improper drawing of ROI. Otherwise,
sir.
we can't explain
Yeah.
this.
या शायद लैसिक्स भी सर कभी कभी F-20 और F-0 दिया होगा, वहां पे भी
Yes, sir.
थोड़ा सा गैप आ जाता है.
बिल्कुल.
अगर
Yes, sir.
पता नहीं एग्जैक्टली कब लैसिक्स दिया है.
And sir, this CT eye view also showing that very less contrast excretion. Very, matlab, it's near to the negligible. That is also like in favor of the very less functional kidney. Then again,
No. You see, don't get into this. What the decision you will take is based on age of the patient, cortical thickness, and symptoms. Okay. CT urography, frankly, I would really think whether CT urography is really needed in this patient. Because I want an anatomical study which NCCT will give me. I want the functional assessment which DTP urinogram will give me. There is very less that contrast CT will add in this patient. Yes, your answer was good that you will see a crossing vessel, but as Dr. Hiren had asked you, does it really make a difference? Finally, you can identify that even during your procedure. Means you don't need to plan your procedure based on whether the crossing vessel is there or not. Whether you see the crossing vessel or not, how much does CT crossing vessel seen on CT corroborate with your intraoperative findings? Okay, even that is not 100%. It happens that you see preoperatively on CT there is crossing vessel, intraop you don't find something or other way around. So this means CT urography is debatable in this patient.
And you cannot say delayed contrast, negligible contrast, because delayed contrast can come in severely obstructed kidneys. In our days of IVPs, we used to see 24-hour nephrogram, but those kidneys were good. We had to save them.
Akshay has asked, is there any absolute answer? Yes, there is absolute answer. You have to decide it. Either pyeloplasty or nephrectomy, you have to defend it.
Now you want
That's
to change
that's
your
all.
decision?
Yes, sir. Yes, sir.
Okay.
But
So
patient is
not-
young, so we will do shared decision making.
So you decide first ki pyeloplasty,
So
nephrectomy.
not
Summarize
only
the
even in
points in
exam,
your mind
even
and
when
tell to
in
the
the
examiner.
practical, when
These
you
are the
start your
points why
practice
I have
also,
decided the
you know,
pyeloplasty, our nephrectomy.
think twice before going for a
आप ऐसा
nephrectomy or
शेयर्ड डिसीजन बोलोगे तो एग्जामिनर बोलेगा डॉक्टर साहब पेशेंट बोल रहे हैं मैं तो आपके पास आया हूँ मेरे को कुछ मालूम नहीं आप ही मेरे लिए डिसाइड कर लो
No shared decision.
डोंट से
Decision
दैट इन द
has-
एग्जाम
okay.
Dr. Philip has asked any indication for nephrectomy in asymptomatic non-functioning kidney.
Yeah. Amit,
What-
answer now.
He himself, if he is saying a symptomatic non-functioning kidney,
He has said
He
he himself is giving
non-functioning.
indication.
No, non-functioning kidney when you will do nephrectomy.
Sir, non-functioning kidney is the core.
Come on,
All obstructed, symptomatic or non-symptomatic hydronephrotic kidneys
Okay,
should be
so I'll
removed.
tell you. For example, kidney like this. If it is a very big kidney, there are chances that even a small trivial trauma can lead to bleeding and injury to the kidney. Second thing is if the kidney and any non-functioning kidney is giving severe hypertension. Okay,
infection
then it is infected kidney. Third, there is a calculi disease. So, or if it is a tuberculosis, or there is a malignancy, or is a very symptomatic. Patient has got either hematuria or patient has got a pain. So these are the indication. Even if it is non-functioning kidney small, you must operate. When all these things are not there and it is just silent, non-functioning kidney, you can leave it there. Any other question?
I think good, sir. We can move to the next case.
Yeah. Okay. So Bridget, who is answering and which case you are presenting?
So we will present another BPH case.
Okay. So who is going to unmute themselves?
Yes, sir.
So Solairaj and Mukkani.
Good evening, sir. This is Dr. Soleiraj, sir.
Fine. So you got a history with you, correct? History and examination.
Yes, sir.
Yeah. So he will show you the slides, and you please go through your history and examination. Okay.
Yes, sir.
Brijesh,
Yes, sir. It's loading.
So 57 years male patient came with complaints of difficulty in passing urine since 2 months. This patient was apparently asymptomatic 2 months back. He started developing difficulty in passing urine, poor flow associated with poor flow.
चल भाई मेरा हो गया क्या क्या काम बचा है
Hesitancy, urgency.
क्या करना है
Avoiding symptoms of
Akshay,
किसका किसका ट्रांसप्लांट वाले का क्या करना है
Mute yourself.
Akshay, please mute yourself.
ठीक
symptoms are serious in onset, gradually progressing with no specific aggravating and relieving factors associated with straining during passing urine and nocturia 2 times per night. IPSS score was frequency 2, urgency 2, nocturia 2, P1, Poor flow 1, intermittency 0, and S0, SAEV 3. No history of hematuria, dysuria, no history of burning micturition, no history of previous instrumentation or catheterization, no history of abdominal pain, vomiting, no facial puffiness or backache, and no history of past history is a known case of diabetes on tablet metformin for 500 mg BD for 2 years, and no significant family history. Mixed diet, adequate appetite, bowel habit normal, bladder altered as described before, sleep disturbed due to nocturia, non-smoker, non-tobacco chewer, non-alcoholic. General examination, patient is conscious, cooperative, well-oriented, widely stable, and head-to-toe examination, spine examination, grossly normal. Local examination, patient examined in supine position with the inclined consent, exposed external genitalia normal, uncircumscribed patient, spinal matrix normal, all hernial orifices normal, no palpable urethral thickening. No fissure, no fistula, no hemorrhoid, channel to normal, prostate grade to enlarged, firm in consistency, smooth surface, non-tender, median sulcus palpable, rectus mucosa mobile, and rectum empty. No blood on glove. Per abdomen, patient is examined with consent, inspection normal, palpation normal, percussion normal, bladder not palpable and palpation, and auscultation normal. Systemic examination normal. So, to summarize, my patient is complaining of difficulty in passing urine since 2 months with poor flow, increased frequency, IPSS score of 10, moderate in severity, and diabetic who's taking metformin BD for 2 years. On examination, benign grade 2 prostate, firm in consistency, smooth surface, non-tender, median sulcus palpable. So, probable diagnosis is BPH with moderate severity of IPSS.
Good. So how do you want to proceed further?
Sir, basic investigations like
No.
care,
Have you asked about the quality of life and the sexual activity?
we have asked quality of life and physical activity.
Okay. Okay, now answer. What you want to do now?
Sir, basic investigations like urine routine, urine routine, CBC, KFT, and ultrasound with post-viral residual urine, ultrasound whole abdomen with post-viral residual urine, and uroflowmetry, serum PSA has to be done, sir, as a routine. So our patient's hemoglobin is normal, TLC 7000, serum PSA 1.28, HbA1c 6.6, and creatinine normal, sodium potassium normal, sir. Next, we will ask for urine routine microscopy. pH 6, specific 1.015, RBC occasional, pus cells 15 to 20. As there is pus cells, significant pus cells, we have to ask for culture test, no growth. So, as patient is diabetic, I would also like to do fungal KOH mount.
All were negative.
And ultrasound whole abdomen with post-viral residual urine.
So in all diabetic, you are going for fungal KOH mounting. That's what you told.
In our hospital, we routinely follow this.
because it is available there.
Yes, sir.
You see, Dr. Solairaj, I would want to say something. When you make such comments, you are challenging the examiner to discuss with you fungal UTI.
Yes,
Okay.
asking
So
for trouble.
PPH kahin bhi reh jayega and we will start talking about fungal UTI now. Okay, so get into such waters only when you are sure you want to go there.
Okay, sir. Sorry, sir. So ultrasound whole abdomen with post-vessel urine will be asking.
What is the age of the patient?
57.
Age कितना है?
57.
57.
57.
57. Okay.
Uroflowmetry, sir.
So you go for sonography or uroflowmetry?
Sir,
Uroflowmetry.
Okay.
Okay. So, Mukani, Velan,
Yes, sir.
this is the
Yes, sir.
uroflowmetry. You don't want to do sonography?
I will do, sir.
Pardon?
I will do, sir.
We always are teaching you, na? It is an extension of clinical examination.
Yes, sir.
Okay, what is your interpretation of this?
The uroflow is over prolonged pattern with
Pardon?
Qmax of 6 ml. The uroflow is a poor prolonged pattern, sir. It's a Qmax of 6 ml with a voided volume 300 ml, sir.
Okay.
so this is looking like box pattern appearance, sir.
I'm sorry, I missed it. What appearance you said?
Box pattern like appearance.
Box.
Box.
So if you are
Stricture.
box, so you are suspecting stricture?
No bell-shaped curve there, like this.
How will you clinically decide, differentiate, sorry, how will you clinically differentiate this patient has a prostate or stricture?
From the uroflow, sir.
No, clinically.
Listen, clinically means clinically.
By history, patient will tell once he started passing urine, there will be some difficulty at the penile or near the perineum, sir, while he is passing.
What happened to the stream if patient strains while passing the urine? In stricture and in prostate.
In stricture, there is not
In a
any
prostate,
What?
in prostate, staining increases the flow, sir.
It decreases or increases the flow?
decreases the flow, sir, in prostate. In stricture, the flow will be same, sir.
Same or increase?
Increases in prostate.
So Velani, you
Increases or
answer now.
decreases? Don't get confused. Increases or decreases in prostate? What happened in prostate? If it increases or decreases?
Decreases because there will be median loop protruding into the bladder, and then it causes decrease in flow, sir, in prostate.
And it increases in the stricture.
Okay.
Because if you are applying more force to pass the urine through a small tunnel.
Okay, sir.
Okay.
Okay.
So if it is increases in the stream is increasing, then probably it may be stricture. In case of prostate, if you give straining, either if patient is a trilobar prostate or bilobar prostate, the stream will get decreased. In trilobar, the third lobe will act like a ball mechanism and everything will get closed. And in bilobar prostate, the bladder neck will get closed.
Okay.
So next time when you are doing cystoscopy in an enlarged prostate, you know, what you should do is put a cystoscope, fill up the bladder, come out till the verumontanum and try to put a pressure on the abdomen and see what is happening. Okay?
Okay, sir.
You will understand the mechanism. Okay, fine. So now you still feel that this is a box type?
No, sir, this is not box pattern.
So how do you,
Okay.
what is the difference between box pattern and this pattern?
Just a prolonged
Is
pattern.
this
The box
patient
pattern will
having
be
hesitancy?
the dips will be there, multiple dips will be there.
In what?
In a stricture urethra, that box pattern, sir,
There will be multiple dips.
means it will not be smooth. The curve here is the upper part of the curve is smooth. There will be not be smoothness in the box pattern.
Rather, the box pattern will be more smooth. You see, box pattern is sudden upswing, and then a continuous flow, which doesn't change much till the patient completely empties his bladder. Rather, in BPH, whenever he intermittently strains, the flow may have a wavy pattern. Why this is not box pattern is because for it to reach the peak flow, it has taken some time. The rise of peak flow is very acute in box pattern, and here it has been a gradual rise. So this is not box pattern.
Okay, sir.
Have I conveyed what I want to say?
Yes, sir.
Yes. And box pattern will never be wavy at the top. It will be nearly a straight line.
Okay.
You know, if we get a box type of pattern, 2, 3 patterns, I will present you next time. Just show you. Then you will realize. Fine. Okay. So now, Vijay, show them ultrasonography. Okay, Velani, can you read it and tell us?
The ultrasonographic images of the from the top right kidney and left kidney, showing normal right and left kidney, and also the sagittal images of the bladder can see. Is there any more images available, sir?
Any more images, Brijesh?
This image is only this.
Okay, this is the only one.
Few simple cortical cysts is there in right kidney. And median lobe of prostate is protruding into bladder lumen. Intravesic section of prostate is seen.
Hmm.
Homogeneous prostate echo texture is seen.
What about the bladder?
Bladder wall is not thickened much, smooth in bladder wall thickness, and there is no filling defect in bladder wall.
Filling defect in bladder wall. What does that mean?
In the sense there is no mass lesion in bladder.
No diverticular.
So no space occupying
No
lesion, not
diverticular.
filling defect.
No space occupation.
So from on the left hand side from above, you come down to the third film. So what you are seeing there? Hmm. See, it is a very quite a lot distended bladder. So in that, even if there are saculations or trabeculations, will not be seen very clearly. Even the thickness may not be seen properly. But if you see on the right hand side above the second film, just see it. All the films, if you see, there is definitely irregularity. Show the report.
Ultrasound is showing pre-wide residue of 300 cc and post-wide residue of 270 cc with a moderately enlarged prostate of approximately 52 grams with intravesical extension of 11 mm for grade 3 along with the left simple renal system.
Okay. So now, next one. What do you want to do? So my question is whether means this patient has come to me and I decide giving him, he has not taken any medical treatment. I want to give him medical treatment. Velani, what is your view?
It's a combination therapy, sir. Since the brand is more than 40 cc, I
You
would
want
like to
to
offer him
give,
the combination.
no, you agree with me.
So
For
the
medical
first
therapy,
question is,
you're
would
asking,
you
sir.
advise medical management, or you would say no, medical management is not justified?
Sir, I disagree with that, sir. Since there is an intravesical extension of more than 10 mm, I would like to offer the patient, I will discuss with the patient counselor regarding that and need for a surgical management for this patient, sir.
So your decision is
So-
based on IPP.
So please try to understand.
Post-vital residue.
Don't tell directly anything in the exam.
Okay, sir.
Think thrice, 10 times before telling the answer in exam. ओनली इंट्रावस्टिकल एक्सटेंशन अभी 2-2 सेंटीमीटर का इंट्रावस्टिकल लोब रहेगी भी अगर सिम्टोमेटिक नहीं है,
Post-vital residue.
पोस्ट-वाइटल रेसिड्यू ज्यादा
PVR
नहीं,
of
क्यों सर्जरी करना है? तो बहुत सारे फैक्टर्स है, अभी डिस्कस करेंगे वन बाय वन, लेकिन बोलने के पहले सोचो.
So that is why I'm asking you, okay, will you like to give a medical line of treatment? Think, okay, in this patient, are you justified in giving a medical line of treatment? If yes, then what are the reasons? And then you say, yes, sir, I will like to give medical line of treatment and these are the reasons. You say, if you don't want to give medical line of treatment in your mind, just give 2 minutes and decide why you don't want to do and why you want to do surgery. So, Velani, tell me what you want to do and why. So, Lairaj, you are ready?
Sir.
Okay, Velani, tell me what you want to do.
This patient post-vital urine is more than 200 ml, like around 200 ml out of 500 ml. Sir. So first we would like to I would like to catheterize the patient, and his first cells in urine was also 15 to 20. So to decrease the urinary infection, UTI chance of UTI, I want to catheterize him and then give trial of medical management with the combination therapy. And after 4 to 6, like after 2 weeks, we can remove catheter and give trial of voiding. And as per his symptoms, we can assess his, like we will do post-vital residual urine again after 1 or 2 weeks, and then assess how is responding, sir.
So, Velan, Mukkani.
Sir, yes, sir, yes, sir.
You agree with him or you want a different plan?
Yes, sir, I agree with him, sir.
So I'm giving you 3 options.
With...
I am giving you 3 options. You
Okay.
catheterize the patient and give him the medical line of treatment. You don't catheterize patient, you give him a medical line of treatment. And third, you offer him surgery.
I will offer him surgery, sir.
Okay. You are offering him surgery. What is the justification? And why you don't want to give medical line of treatment and why you want to do surgery?
So, from the history, I saw that IPSS score 10, sir. The moderate symptoms are there. Then after that, coming to the investigations, the prostate size is 50 cc, PVR of the 300 cc, and the Qmax in the uroflowmetry. And the Qmax is also only 6 ml. So average maximum Qmax is only 6 ml. So based on this, I feel that if the patient is given a trial of medical management, the chance of failure are high. So I will discuss these things with the patient.
So, Velang,
Yeah.
my question is, if
Yeah.
the patient tells you, okay, sir, if you give me medical line of treatment, and if I come after 1 month, is it going to deteriorate or am I going to get more complication? What will be your answer?
I will say that to the patient, it may go into acute urinary retention. Chances of going into acute urinary retention are there.
Without medicine or with medicine?
I will expect it.
So, if the patient goes into acute retention,
So
what you do?
I'll put a catheter, sir.
And
First, so I will continue the. So if we started on medical management, if the patient goes into acute
which
retention,
drug you will give?
I will put a
Which
catheter.
drug you will give? Which drug you
Combination
prefer
there,
for
alpha
acute
blocker also.
retention? Which alpha blocker is best for acute retention? I am giving you choice: alfuzosin, tamsulosin, and silodosin.
Silodosin.
Okay, so you'll give silodosin, and after how many days you will remove the catheter?
I'll wait for a first trial of void. I will wait for 3 to 5 days since the chance of successful trial void increases after third day, sir. So after 5 days, I will try to remove the catheter
So
and see whether the patient is
after
able to void.
so even in acute retention, you are expecting that this patient will void after 3 or 4 days of silodosin, correct? Right or wrong?
In retention, yes, sir. Yes, sir.
Right? So that means you believe in medical management.
Sir?
Yes or no? So you believe in medical that even in acute
So can
retention, if you use silodosin, there are good chances that patient will pass urine after removal of the catheter.
may
Right?
void. Yes.
Okay.
Yes, sir.
So now, so let us come to this case. Then in this case, why you don't want to offer medical line of treatment and see what is happening?
Because I felt that the prostate size to be more this one and the large PVR and the Qmax is very low. So the chances of refractory or failure of the medical management are high. So I felt initially I offered the management for patients.
Okay, then this patient comes after, if you do medical line of treatment, you review him after 1 month and then see if the patient has not improved, you are offer him surgery. Is it wrong or is it right? So like that, what will be your answer? Acha, you have already said you want to catheterize the patient. I'm again giving you choice. Catheterize, don't catheterize and start medicine, and surgery. So what is your choice?
That patient is diabetic, sir, and he's symptomatic. So I don't want to take any risk of UTI and urosepsis. So I would definitely like to catheterize for a few days at least, like 1 week or something, and then give medical management and then let him improve the left sphincter relax, and then I will give a catheter-free trial.
Okay. And okay, the surgery management. So Gita sir, how they should answer in the exam?
This patient, if the same question asked to me, I will consider following points. Number one, he is a 57 young diabetic. I will say he is young diabetic. Is he sexually active or not? Number two. Number three, his symptom scores, IPSS score, mild, moderate, severe. Number four, Qmax, and average, though both can be seen. Post-void residue, single post-void residue to that, what is the pre-void? I am interested in pre-void. Pre-void and post-void, single रीडिंग है. उसके बाद में इंट्रावेसाइकल लोब का लेंथ, उसके बाद में बॉदरसम इंडेक्स है नहीं है. उसके बाद में complication of, if you are suspecting BPH, is there any complication of BPH like diverticulum, stones, hematuria, upper tract hydronephrosis? Is there anything in that? Then bladder wall thickness, then PSA and size, and age of the patient. All these factors I will take into consideration and I will decide is he fit for medical treatment or he is fit for surgical treatment. And if he is fit for medical treatment, then what is the PSA and what is the size of the prostate? As per on that, I will decide it is a combination treatment or single drug treatment. Then single drug treatment is sexually active or not, then which single drug can be given. That on that point, I have to decide which single drug I have to give. So this is classical, given everything in the book. Nothing. अपने दिल से कुछ बताने का जरूरी नहीं.
So like that, sir has told you all the points. Okay, the patient is
So
young.
if any point,
Patient-
if any point I have missed, Pankaj sir, please add.
No, I think you have covered everything. So, you see, among the indications for surgery, post-void residue does not feature in the indications of surgery. So don't base your decision. So IPSS score is not very high. It is just 10, 11. Post-void residue, as it is not significant, prostate size is not important in decision making. So your decision is based on patient symptoms, bother score, complications, uroflow, and then other factors. Okay. If you feel like Dr. Gaurang Bhai was asking you repeatedly, can you not give him medicines? And if you have already committed for surgery, then you should be politically right in exam. The best way to say in exam is, sir, I would advise surgery, but if patient insists on medicine, can be given a trial, explaining him well that this may not work over long run. Okay, so if you anytime sense that your examiner is taking you towards medical management, don't block him. Let him take you there. So now, based on what Dr. Gite Saab has said, what would be your decision now?
So,
One more point I have forgotten. Young and diabetic. That is
Yeah.
another indication for urodynamic study.
Yeah, exactly.
So if you tell in exam, I will as there is a 20 to 15 to 20 pus cells and patient is symptomatic, I will start the antibiotic. Under antibiotic cover, I will go for the urodynamic study. I will confirm that is there any bladder component is there or prostatic component is there. ये चल जाएगा. स्पेस भी मिलेगा आपको सांस लेने के लिए, सोचने के लिए. यहाँ से भी आगे आप मेडिकल और सर्जिकल ट्रीटमेंट में जा सकते हैं. Please go ahead. Please go ahead.
Yeah. Okay. So like that,
sir,
as
so
per
we should not catheterize. We will just go for medical management and then see how patient's symptoms improve, and then if he is not improving, we'll give surgery.
so like that,
Yes.
now we are at the final stage. Okay. Dr. Gite has already given you the point. Now you take each point and tell us that whether it is significant or it is not very significant, means for the surgical point of view. So start with IPSS score. IPSS score, is it very poor?
No, sir. Moderate.
Means, so it is okay. Second thing is prostate. Is it very large prostate?
No, sir. 52 cc. No. 52.
50. Okay. Third thing,
Just one line I want to add. Size of the prostate doesn't amount for amount of obstruction.
yes.
Okay. Prostate size is important in deciding combination treatment or single treatment. Then configuration of prostate, again deciding the type of the treatment, trilobar, bilobar. Size of the prostate is important only in deciding the type of the treatment. If it is a 200 gram, yes, there may be laser surgery can be done. If open surgery can be done, retropubic, Millen's prostatectomy or phase prostatectomy, or transvesical laparoscopic or robotic prostatectomy, large size के लिए. तो लेकिन obstruction का और size का कोई संबंध नहीं है.
Correct. Okay. Now show the Uroflowmetry. Brijesh, just show uroflowmetry. Because here they are showing that he has passed only 40 cc from 309 to 270. Brijesh?
No, sir, he's passed 200 ml from 500 to 309.
Acha, okay, first void is 39. Okay. So he's passing a large amount of urine.
So his voiding efficiency is around 40%.
Yeah. So that is another thing. Now, next is infection. Yes, he has got a pus stain. But he doesn't have any upper, there is no hydronephrosis, correct? So upper texts are not involved. So now, considering all these things diplomatically, because some cases are such that examiner may say, no, you go for a surgery. Some examiner will say, you go for a medical management. So in this case, as Dr. Pankaj Maheshwari said very rightly, you can say, sir, I will like to give medical management initially because patient has got infection and all these things. And then add what our Dr. Gite has said, is that he is a young fellow and he's a diabetic. So before doing any surgery, I will like to do urodynamic study, confirm it. And if the medical management has failed, then I will go ahead with the surgery. Gita sir, is it okay to say like that?
Yes, sir.
I think that it will cover whoever is the examiner, it will satisfy him. Correct?
Yes.
Okay. So any questions from other students?
Sir, you asked one question that does dalfuzocin or silodosin is better for TWAC? So
yeah. So there are many studies, and initially when silodosin was not there, the trials were done with other alpha blockers. That time we had a prazosine, we had doxazosine, we had temsulosine, and we had alfuzocin. And some of the trials they said alfuzocin is, better for the acute retention. And when you catheterize, and now they are saying even silodosin is one of the preferred drugs. So
okay. Like
single
answer, what should we say?
Silodosin. See, silodosin is supposed to be the drug of choice, but still
The
you can read into
alpha
the
blockers is highest for silodosin among the 3 drugs. So if you want a faster effect, which you want in a patient where you are trying to give a trial without catheter, then the drug of choice could be silodosin. Over long term, the impact of all 3 alpha blockers is nearly the same, but they differ in the say duration of action, means how fast the action starts, and in the side effect profile.
Okay.
Now, if you answer alfuzocin in this patient, I will be more happy.
Yes, sir.
Because he is young.
Exactly.
Yes. Alfuzocin also effective, equally effective. Okay. Any other questions from other students?
So this patient has read about mist and wants to know whether mist can work for him. So what would be your answer to him?
Yeah. Velan. Now this patient, the latest management, definitely, because nowadays many people have done the trials and they are using many other newer techniques. So you should be aware of all these things. Huh?
Yes, sir.
Yeah, tell us.
The patient requests for such treatments, sir. That time you are asking.
Yeah.
Again, what did you say?
You can tell the option of Eurolift for the patient is very young. simplify only so that the sexual function can be preserved better. Urolift.
So for this particular
No.
patient, which missed therapy will be optimally
Better.
applicable?
Follow-up.
So which are the, Dr. Maheshwari is asking you what, which are the latest therapies? You said Urolift. Second is,
No, sir. Urolift, medial lobe is there, sir, so may not
so
be
you cannot.
effective.
Okay, so one is Urolift, but in this case, otherwise he is ideal, but he has got a medial lobe, so he will not like to use it. Second,
Resume
therapy.
therapy.
okay. So in this case, will you like to use resume?
Yes, sir.
So now there are a few suggestions I want to give you. First and foremost, don't call it resume or Urolift. These are trade names. Okay.
Okay, sir.
In exam, try not to use trade names. So
Okay,
instead
sir.
of Urolift, you should call it as prostatic urethral lift. And instead of resume, you should call it as water wave thermotherapy.
Okay, sir.
Okay. Now,
Okay, sir.
say prostatic urethral lift (PUL) can be done for patients with small median lobes, though ideally patients with median lobe should be avoided. If there is a small median lobe, then what can be done is one clip can be applied, pulling the median lobe inside the prostatic urethra. That is called as MedLift protocol. But we have other options available. The next resume can be done in patients with large median lobes. Resume can be done even in patients with large prostates. The plus point of resume is yes, it can work with large median lobe, but the negative point is it will need catheter for a prolonged duration. And in resume, you cannot assure antegrade ejaculation, which you can assure in Urolift. What are the other missed therapies you are aware of? Other than
What about this
and this thing?
newer that sling method?
Which method, sir?
Sling. Today only someone had come and he said that they put a sling and it causes the over the period after 72 hours or this thing, it causes a necrosis of the prostate.
You are talking of itin, sir?
I think so. I was
It
little
is
in
not a
hurry
sling,
coming
sir.
here.
It is a triangular device which is placed in prostatic urethra and
Okay.
which is used for small prostates with predominantly bladder neck obstruction.
Tinid.
Itin. Yes.
Yeah, but he told me that it will cause you remove it and it will cause the necrosis.
Yes. So it causes a pressure necrosis, sir, at 5, 7, and 12 o'clock position.
Okay, fine. So this is also many centers are using it. That is what he said.
And
I
what
will
about
come back. Anything else?
aquablation?
Sir, aquablation, is it a mist? We want to use a robotic arm like that.
Aquablation, you are absolutely right, is not a mist. Aquablation is rather an ablative procedure. It uses high pressure water, which is controlled by a robotic arm. And the advantage of aquablation is that it can maintain antegrade ejaculation in more than 95% patients.
Sir, what about prostatic injections?
Prostatic injections are nearly outdated now. There are few studies being done with botulinum toxin injection in the prostate. There were older studies where they had injected ethanol in the prostate, but intraprostatic injections are nearly not done today. So if we have to talk about missed procedures, then there is
Embolization. What about
uh,
embolization?
sir, I'll come to that. So missed procedures will be prostatic urethral lift, water wave thermotherapy, iTind, and last will be this What is that?
Aqua.
No, the balloon with
Microwave.
no, sir.
Optilium.
Optilium, yes.
Optilium.
So these are the 4 procedures that you will use, Optilium. So these are the 4 FDA approved mist procedures. PAE and aquablation do not come under mist procedures.
Okay.
Hmm.
All of you understood? Is very important in the exam.
Paras, Optilium is used both for strictures as well as prostate. For prostate, you have Optilium which has a dual balloon. So the inner balloon holds at the bladder neck, and then there is a prostatic balloon which over there is paclitaxel. So it ruptures the anterior commissure and delivers paclitaxel there. And that being an antifibrotic agent will reduce the chance of say closure of that anterior commissurotomy. But Optilium is used for BPH, is used for urethral strictures, and also used for uretric strictures.
Okay. So, Mukani, can you just summarize whatever Dr. Pankaj Maheshwari has said? And then we'll go ahead.
Yes, sir. Sir has said about the mist procedures, FDA approved, the prostatic urethral lift, and then water vapor therapy, and then Optilium, and then I-10, sir. These are the 4 FDA approved mist procedures available now.
And other 2?
Other 2 are aquablation and also sir, other one is aquablation.
PAE, yes.
Embolization.
Prostatic, yeah, artery embolization.
Embolization.
Right? Okay, so these
Yes,
are the, yeah. So someone has asked QNA and QMT. It is included in MIST or it is not included?
It is not included. Both there are no like in the recent AU guidelines, they have said that because there is no work happening on TUNA and TUMT at this time, they have not considered them in the procedure list. So these are procedures which were done in past, no longer done now.
Fine. Okay. So can we go ahead with the last case? Brijesh, last case.
Yes, sir.
Okay. So, Dr. Rathore,
Yes, sir. Speaking, sir.
you are presenting?
Stricture urethra, sir.
Okay, start.
Sir, my patient is 31-year-old male, come with chief complaint of difficulty in passing urine since 6 months, decreased flow of urine and incomplete voiding since 1 month. Next slide, please. Patient was apparently asymptomatic 6 months back when he started developing difficulty in passing urine. Patient initially would strain to pass urine, but since last month, patient has increased sensation of incomplete voiding with very poor flow, increased frequency. Symptoms were insidious in onset, gradually progressing with no specific aggravating or relieving factor. Initially, he used to void 7 to 8 times. Now he has to void 12 to 13 times a day. These symptoms had severe impact on patient's daily activity. Next slide, please. No history of burning maturation, no history of previous instrumentation, no history of hematuria, lithuria, abdominal pain, vomiting, fever, facial puffiness, exertional breathlessness, lower limb edema, backache, bony pain, or weight loss. Next slide, please. There was in past history, no comorbidities, no COX, no DM, no hypertension. Family history not significant. Personal history suggests diet mixed with appetite adequate, bowel regular and normal, bladder altered as described before, sleep disturbed due to nocturia, habits non-smoker, non-tobacco, fever, non-alcoholic. General examination suggests patient is conscious, cooperative, well-oriented to time, place, and person. Pulse is 72 beat per minute. BP is 112/82. Respiratory is 80. Febrile, SpO2 98 at room air. BMI is 22 kg per meter square. No General physical examination says no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, head to toe, spine examination grossly normal. Local examination suggests present in supine position with implied informed consent with exposure from the nipple to knee in adequate room light, external genitalia normal, circumcised, penile meters normal. For rectal examination done in Sims position, no fissure, fistula, hemorrhoid, anal tone normal, prostate normal, firm in consistency, smooth surface, no tender, median circle palpable, rectal mucosa mobile, rectum empty, no blood on gloves. For abdominal examination, patient examined in supine position with implied informed consent taken with exposure from nipple to knee in adequate room light, inspections umbilical centrally placed, all quadrant moving equally with respiration, no scar, sinuses, ingos, vein, no local rise of temperature, no tenderness present, bladder not palpable, penis normal, circumcised, no any abnormality on palpation, no palpable urethral thickening. Percussions, tympanic nodes present all over abdomen, normal liver dullness. Auscultation, normal bowel sound present.
Okay, fine.
Respiratory is
Yeah.
normal.
Go ahead. Yeah.
So
everything is
other systems are normal.
okay. So Prashant, now this is the history. What is your clinical diagnosis?
Sir, patient is a young male without any comorbidities, and he complains of decreased urinary flow and increased frequency. There is a obstruction, and one significant history is circumcision. He had undergone circumcision, sir. I would like to know the histopathology report of circumcision.
Okay.
So patient had circumcision at birth. It was a religious one.
Okay, sir. Sir, and there is a obstruction to the flow of the urine, sir. As such, a prostate is all normal, sir. And in young patient, I would first think of stricture urethra, sir.
So in the history Dr. Gite had told you, is there any significance in the history?
Sir, he has difficulty in passing urine, decreased flow, and increased frequency of maturation.
No. Brijesh, just show him. What about the staining? Yes, definitely mentioned, if I am not mistaken, that the flow improved on staining. Very poor flow, increased frequency, symptoms were onset. He used to void. Symptoms were severe.
He was initially used to strain, and the urine was he was able to void on staining, but since last month he has aggravated all the symptoms.
Next slide. No, you have written, na, when he used to strain to pass urine.
Yes, sir, written.
Yeah. So, as Dr. Gite said, you can conclude something.
Yes, sir. In this patient, when there is a patient is trying to strain to pass urine to increase the flow, that we can think of first as a stricture, sir. If on straining it is sir, because as Gite sir told, when forceful flow of the channel through a small hole is made, it will increase the stream. Whereas in case of prostate, ball valve mechanism can act and can block the bladder outlet. So even on straining, there will be no flow of urine.
Second thing, what is the age of the patient?
Sir, very young, sir, 31 years, without any comorbidities.
So, if same thing is, it can be applicable to the dysfunctional voiding, as well as another is a hypotonic bladder. If he uses abdominal muscle to pass the urine, then there will be increase in force, increase in the stream of size of the stream. Sorry.
Yes, sir, but the history.
So to have a stricture, what factor you are expecting? This patient has a stricture. Is there? He has a recurrent UTI, peritoneal discharges, instrumentation, catheterization, operation, anything, trauma, कुछ है क्या?
nahi hai, sir. I want to know sexual history in this patient, sir. Whether he had any multiple sexual partners.
So without ruling out, without identifying the cause, if you are primarily expecting a idiopathic cause and going for stricture in a young patient, it can happen, but you have to take other diagnosis in consideration also.
Yeah, sir.
Yes,
It
sir.
can be vesical calculus also, sir. The patient can have a vesical calculus. That can be explain the most of his symptoms also.
That would be my second diagnosis, sir.
Okay. So now tell me the differential diagnosis.
Sir, first diagnosis, first DD will be stricture urethra, sir. Second differential diagnosis will be vesical calculus, sir. And third DD will be any rare mass in the urethral mass, sir.
And whatever Dr. Gite said, this
idiopathic cause can also be, which is because of the childhood perineal trauma. It may cause later in adulthood strictures.
Don't assume and assume and assume.
Yes, sir.
Okay. तो जो ये पेशेंट में है सिम्टम्स उसके हिसाब से ही बताना.
Sir, dysfunctional voiding can be there.
हाँ, anything can be there ना. तो सीधा एक स्ट्रक्चर आपने बोल दिया, that. Another thing, intermittent obstruction अगर हो रहा है, intermittent associated अगर ये retention में जा रहा है patient, तो small stone blocking the voiding long term रह सकती है. That is another bladder stone. लोकली फाइमोसिस रह सकता है, मियाट्रस, लेकिन वो एक चीज है. कंजेनाइटल कुछ अगर सर्जरी हुई वाली है तो हाइपोटोनिक ब्लैडर भी ऐसा सेम पिक्चर आ सकता है. डिस्फंक्शनल वाइडिंग में यंग पेशेंट में यूजुअली ऐसा पिक्चर आ सकता है. तो बहुत रेयर चीजें नहीं बताना है. यूरेथ्रल लैन एग्जामिनर विल आस्क हाउ मेनी यूरेथ्रल मास यू हैव सीन. अननेसेसरी वो यूरेथ्रल मैलिग्नेंसी के ऊपर वाया जाएगा, सीधा साधा स्ट्रक्चर पे खत्म होने वाली बात यूरेथ्रल मैलिग्नेंसी पे जाएगी, अपन फंस जाएंगे.
Yes.
Very simple. What sir has said, 3 or 4 differential diagnoses. One you said very rightly, it is a bladder outlet obstruction. Young patient, you are suspecting stricture or urethral stenosis. Number 1. Second thing, as you said, it can be a vesical calculus causing intermittent obstruction or obstruction. Third is, as you said, dysfunctional voiding. Okay, because he is young.
Yes, sir.
Right. Okay. Now, someone had already said, don't say idiopathic. What is the meaning of idiopathic? When the doctor is idiot, patient becomes pathetic. Or when the patient is idiot, doctor will become pathetic. That is idiopathic. So please understand that. Don't talk about that. Talk of common thing in exam. And there will not be any problem.
I am used that word idiopathic in
no, not with you, sir. He is checking.
Causes of stricture.
Yes.
Not a diagnosis. Not a
Not
diagnosis.
a diagnosis. Yes. Fine. Okay. So next, what you want to do?
Sir, I want to do a basic CUV, sir, and uroflowmetry, then ultrasound PVR, sir.
Okay.
In exam, please use complete words. CUV, PAE, FUV. कुछ नहीं बोलना है सर, सीधा सीधा बोलना है ना. यूरिन रूटीन एग्जामिनेशन, कंप्लीट ब्लड काउंट,
yes, sir.
1 random blood sugar, 1 serum creatinine, 1 ultrasound, 1 uroflowmetry, ultrasound with post-void schedule. इतना मैं प्राइमरी पूछूंगा. जो फिर एग्जामिनर को पूछने दो ना और क्या बोल के. बेसिकली एक यूरिन एग्जाम, 3-4 ब्लड टेस्ट, एक सोनोग्राफी, एक यूरोफ्लोमेट्री, इतना प्राइमरी बस हो गया ना.
Yes, sir.
Brijesh, show them.
Investigation.
Yeah. So these investigations are very normal.
Normal, sir.
Total count is also normal. Okay, go ahead. See the urine routine. Okay.
Yes, sir.
Blood cells are present. First cells are present. Right?
Yes, sir.
Bacteria is also present. So now next, what you want to do?
Sir, I want to urine culture, sir. Has come
So
negative.
there is no growth.
Yes,
So
sir.
there is no growth. Why there is no growth?
So that bacteria which is seen on urine analysis, it would be due to collection, improper collection, sir. There would be some
So
comments.
one is
Patient
one is
doesn't have any
improper
symptoms, sir.
no once you say that it is improper correction. Second,
Sir, a patient doesn't have any symptoms, sir. So this culture report correlate with there will be, I mean, no organism, sir.
okay, or antibiotic. Someone might have started antibiotic earlier. That is also possible.
Yes, sir.
Yeah? And the third thing is that patient may have, like, it may not be actually the infection first cells. It may be just a WBC, like in cases of.
Style period.
Yes.
Yeah, correct.
Yeah.
Correct?
Sir.
Fine. We just go ahead, show them. Fine.
Yes, sir. Upper
Prashant?
tracts, sir, on ultrasound,
Yeah.
kidneys are normal, sir, both sides. There is no upper tract changes, and bladder is well distended. There is a mounting bladder thickness is there, sir, and no, I mean, intravesical no prostate projections are seen, sir. So no other bladder diverticulae or sacculations or any. Their bladder is uniform, sir. So bladder thickening is there. So that is a significant thing, I feel, sir.
And if there is a post-word residue, correct?
Yes, sir.
Little amount. Yeah. We just show the report.
Report shows urinary bladder thickening, sir. It is 4.6 mm with irregular mucosal surface, and the post-word residue is insignificant, sir. Prostate is normal, sir. And there is one calculus 4.7 mm calculus in the upper fourth left knee.
Is it important?
It most of the times it can pass away, sir. That what we can.
That is one thing, and second thing, if there is a calculus
defer to the
disease,
patient.
that can also give rise to WBC in the urine, na?
Yes.
And there may not be infection.
Yes, sir. Blood therapies.
Yeah. Okay, fine. So uroflowmetry. Okay, Prashant.
Sir, this is intermittent uroflow pattern is there, sir. Wavy pattern. Qmax is in the equivocal range, sir. 12.3 ml per second. And so this looks like a intermittent pattern of uroflowmetry, suggestive of dysfunctional voiding, sir.
Rathod, what is your interpretation in this?
Sir, this uroflowmetry shows hesitancy with the Qmax is 12.3 and intermittency, sir, also, sir. Probably.
So that means you are saying that he's training in this.
Yeah, sir. It's
correct.
Probably.
Yes, sir.
But there is no definite box type of graph.
No,
correct?
sir. Yes, sir.
Not a
Yes.
typical that box type of graph.
Not a typical sound, sir.
Okay. So fine. So then what you want to do? Yes,
Sir,
Rathore, bolo.
I would like to
To
do RGU, sir.
RGU,
After
sir.
cover.
RGU. So Prashant, you also, Rathore, you also say RGU and even say the Prashant, you are also agreeing with the same?
Yes, sir.
Yes, sir. RGU, we require RGU. True.
Okay.
Why are you asking for RGU when you are not suspecting stricture on this graph?
So there is
If a post-void residue is a 3 ml, and there is no any history which causes stricture in this patient, number 2. Number 3, graph is also not suggestive of stricture, in spite that patient may be using abdominal muscle and intermittency may be there. That is another explanation for this, in spite of stricture. And symptoms. Yes, obviously there is voiding symptoms. But what is the indication of RGU with this background in this patient? RUG. It is not RGU. It is RUG. Retrourethrogram.
RGU, sir.
Sir, actually, Qmax is not a sustained Qmax, sir. It is peak has gone and it has come down, sir. So if we like to take an average of this wave, sir, it would somewhat appear like a strained uroflowmetry pattern, sir.
So the question is exactly that what has made you suspect a stricture to do a retrograde urethrogram?
46 सेकंड में 200 ml यूरिन पास कर रहा हूँ.
But voiding time is longer, sir.
46 seconds.
Yes, sir.
So it is a prolonged void. So still, why do you need a retrograde urethrogram?
So though voiding efficiency is good because he's a very young patient, he is able to void, sir, complete to the completion. But still, there is this straining pattern, sir, on this uroflowmetry.
देखो, voiding symptoms ये मोटर और पाइपलाइन के जैसा है. सो ब्लैडर में प्रॉब्लम रहेगा या यूरेथ्रा में प्रॉब्लम रहेगा, तभी वो लो क्यूमैक्स से या वाइडिंग सिम्टम के साथ आ जाएगा. अभी इन्वेस्टिगेशन बेसलाइन हो गया है, पोस्ट वाइड ज्यादा नहीं है, लेकिन उसका वाइडिंग सिम्टम्स क्यों है उसका आंसर अभी तक मिला नहीं. बराबर है. अभी नेक्स्ट आपको ब्लैडर को भी असेस करना है कि कहीं उसका पावर तो कम नहीं है या यूरेथ्रा में ब्लॉक है. वो ये दोनों के सिवा तीसरा फिर डिसफंक्शनल रहता है, जो कि ना मैकेनिकल छोड़ के वही एक रीजन है तीसरा. तो ये दोनों में से इन्वेस्टिगेट करने के लिए आपके पास आरयूजी एंड यूरोडायनामिक, इसके अलावा और कोई इन्वेस्टिगेशन है क्या?
MCUG भी
क्लिनिकल हिस्ट्री आपने ले लिया, सोनोग्राफी हो गई, यूरोफ्लोमेट्री हो गई, अभी पेशेंट यंग है, तो अभी इसका कॉज कैसा ढूंढेंगे?
See, sir has given you answer how to explain in exam. Examiner is going to ask you, so why you want to do this?
अभी सर ने पूछा है कि आरयूजी क्यों कर रहे हो विद दिस बैकग्राउंड, या मैं भी पूछ रहा हूँ कि क्यों कर रहे हो.
Sir, because
so justify. Yeah,
sir, one
justify.
point, yes, sir. First point for me, sir, history while straining is urine stream is increasing, and second point, sir, he has undergone circumcision. I can suspect any complication due to circumcision, कुछ metal stenosis.
Most common complication post circumcision in terms of the narrowing, at which place and what it is.
Metal stenosis, sir.
Exactly. तो clinically दिखता है, आपने अगर देखा होगा.
So, sir, as patient is the voiding time is very long, and we are not able to reach on all these investigations don't suggest, don't explain his symptoms, sir. So we want to know we want to reach on diagnosis. So that's why we want to do RUG, sir.
Sir ने already तुमको answer दे
You
दी.
see, the way
He
you
has
will need
said
to
that-
answer this, Dr. Rathod, is first you need to come up with the sequence of differential diagnosis.
Sir.
So at this time, do you justify stricture urethra as the first diagnosis? Means if this patient walks in my OPD, I would not consider stricture urethra in him. There is no instrumentation, there is no urethral trauma or infection. Voiding symptoms can be there in many reasons, and uroflowmetry does not look like stricture at all. So yes, stricture will be there in my list, but it will not be the first thing in my list. So my investigation would start based on what is my first differential diagnosis here. You see, obviously you have been told that this is a stricture case. That is what is making you biased.
Yes, sir.
So
Sir,
why are you suspecting stricture at this time?
Sir, in some parts of the uroflow pattern, the wave is touching the baseline, sir, and is again going up and again touching baseline, sir. So I would first think of underactive detrusor in this, sir.
Exactly. So this does not happen in stricture.
Yes, sir.
So this intermittent flow pattern is not a pattern that you see in stricture.
Yes, sir.
So now, once you have ruled out stricture, now what is your first investigation?
Sir, I would like to do first MCUG, sir.
Hey. UDS, sir.
Direct VUDS.
So what is your diagnosis again? What is your differential diagnosis?
It's maybe the dysfunctional
Sir,
voiding or hypotonic.
Dysfunctional voiding.
It can be the dysfunctional voiding or hypotonic bladders.
Okay. So why are you suspecting hypotonic detrusor?
Because the uroflow pattern, sir, in some parts it is touching the baseline and going up, sir. So he is not able to sustain the detrusor contraction, sir.
So I will tell you what you should say. Dr. Gite and Dr. Both of them are saying. So your differential diagnosis, as you said, that considering this, you want to have a 3 differential diagnosis. As Dr. Gite said, there is either a detrusor with a vesical problem, detrusor problem, or it can be because of the urethral problem. Correct?
Yes.
Now you say, sir, he is a young fellow. Okay. Chances of him having urethral stricture are always there. And I will like to do urodynamic study. But if he has got urethral stricture, I may not be able to do it. Second thing is, if the stricture is, the urethra is very narrow and he has to strain a lot, in that case, we may not get actual box type of flow rate. And this type of pattern can also be seen because there is a severe obstruction and he has to strain a lot. So before doing urodynamic study, this is diplomatic answer. I will like to do RGU and rule out the stricture urethra. If it is not there, I will go ahead with a urodynamic study to find out the detrusal form or dysfunction.
Yes, sir.
Yes, sir.
Or vice versa.
Yes, sir.
So
if you go with the urodynamic study, defense will be more. And अगर urodynamic study करना है मतलब तुमको कैथेटर डालना है. अगर कैथेटर नहीं गया तो urodynamic study कहाँ से करेंगे?
So then you have to do RGU.
Then already you are reached to one diagnosis. So starting with one investigation give clues to the 2 diagnosis. So in this case, I agree with Pankaj sir. I will go initially with urodynamic study if someone has asked me.
Okay, fine. British, now show them what we had done. So we went ahead with the using RUG.
Bulbar.
Just show them. There is no reason to show the writing. Okay. Now tell us what you want to do.
Sir, RGU shows bulbar urethral stricture at 2 segments, sir.
Yes. So what you want to do?
Penile urethra is normal, sir. Sir, so this is a bulbar urethral stricture, sir. I would like next to do a sonourethrogram, sir.
Why?
I would like to do sonourethrogram, sir.
Why?
Sir, this is a might be this is a bulbar urethral stricture, and to look for any spongiofibrosis, I want to and exact again length of the stricture of part of the urethra. I would like to do sonourethrogram, sir.
Why not MRI? If you want to just see spongiofibrosis, then get a MRI done.
Yes, sir. MRI also can be done, sir.
So then what do you want to do?
Dr. Rathore, you agree with him?
As the contrast is going in the bladder posture, so in spite of that, I want to do the VCUG also, sir. That will be functional and anatomical both, sir. And then after that, we don't need because we don't need a sonography or MRI, sir. I think it's a 2 short segment bulbar urethral strictures, and if the posterior urethra is normal, so then we can plan our management based on that only.
Okay, I'm telling you, I don't know. I don't agree that we should go ahead with any other sonography or MRI, because there is no trauma, no instrumentation, and this is a pure stricture. On examination also everything is normal. Dr. Gite, what do you think? You
Sir,
should
even
answer.
I am not advising a MRI. I'm just
No, not you.
Yeah, I'm just trying
with
to
the
tell him
student.
that there is no reason
We
to
understand.
look for spongiofibrosis here. You see, looking at this MCU, it's a very short segment stricture.
Correct.
Okay. We don't see any false passages, any irregularity around. You are not suspecting any periurethral pathology in this patient.
Correct.
So
that is why I'm saying that
yes.
Do you need any investigation after this?
No, sir. We don't think.
So now what you want to do? See, just because you have got many investigations and many
how is
answers.
the bladder neck in this
MCUG? I would like to do MCUG, sir.
How is the bladder neck in that? Probably they have done MCUG. Look like second picture is RUG and third picture is VCUG RUG combination ऐसा रह सकता है, पता नहीं exactly.
The same.
RGV लगता है.
दोनों पूरा दोनों चारों भी.
चारों भी RGV लगता है क्योंकि वो कैथेटर दिख रहा है पिनाइल यूरेथ्रा में.
Pineal urethra में catheter is seen.
Correct.
Because this patient came from outside with this investigation. We had not done it.
Agreed.
Another
thing is that position of this RUG is not good.
Yes, sir.
Number one. Number two, penobulbar plus bulbobulbar, that is mid-bulbar, proximal bulbar ऐसा and distal bulbar and penile ऐसा 2 जगह पे narrow होंगे. एक very short segmental narrow होंगे. और contrast is going inside the bladder. Bladder is अभी यहाँ से कमेंट करना आ रही है, डिफिकल्ट है. तो
I know difficult.
मुझे लगता है इसमें VCUG करे वाला कोई not a bad idea to do a VCUG. Possible if catheter goes from below feeding tube भी गए तो करो, नहीं तो फिर supra भी full करके भी कर सकते हैं, क्योंकि posterior urethra का एक बार नॉर्मल है ऐसा डिसाइड हो गया और कहाँ तक नॉर्मल आ रहा है नीचे, जो प्रॉक्सिमल
Then you
स्ट्रक्चर है
can plan
शायद
the
वो नहीं
surgery.
नहीं भी रह सकता है VCUG करने के बाद में। एक
Right.
स्ट्रक्चर तो पक्का हम बोल सकते हैं जो पेनो बल्बार का है, प्रॉक्सिमल का स्ट्रक्चर शायद नहीं भी रह सकता, तो VCUG इन दिस केस इज इंडिकेटेड, बेटर टू गो फॉर VCUG। अगर कैथेटर नहीं जा रहा है, समझो नीचे से ब्लैडर फुल नहीं हो रहा है या अवेलेबिलिटी नहीं है, तो फिर स्मॉल स्कोप पेडियाट्रिक स्कोप से स्कोप इज अनदर इन्वेस्टिगेशन।
Okay. Fine. Okay. So now suppose let us come all the other investigation or VCUG, everything is okay. Okay. Now
Yes,
what
sir.
is your plan? So Dr. Rathod, what you will like to do?
So, as this structure length is will be around two short segments, so we can't the OIU is not advisable, so I will prefer go for the urethroplasty, sir.
Prashant, what is your view? What you want to do?
These are small, less than 1 centimeter segmental strictures, sir. I would like to do a VIU, sir, direct visual internal urethrotomy. As there was no previous any surgeries, nothing is done. According to AUA guidelines, one attempt of DVIU can be done, sir.
So there's a two structures are there, so I think OIU will be not a better option. So excision and primary anastomosis will be the better
So what
for
is
it.
the meaning? So what is the meaning of two stricture? One. And which stricture will be more dense, proximal or distal?
Proximal will be more dense, sir.
Yes, sir.
Which one?
Proximal one, sir.
At least
Distal.
on
And
the
what?
RGUG, it looks the distal is more dense.
Distal one, so it's distal is more dense. Okay, distal is more dense.
Yes, sir.
Distal is always more dense than the proximal. Because what happens is that first the distal stricture takes place, and then because of the infection proximal, but there is a dilatation, and that is why it is not going to be a very dense stricture.
Yes.
Now, okay, I am giving you three options. One option is patient has got infection, first cells are present, so I will like to do a suprapubic, clear up the infection, and then decide for the definite line of treatment, that is buccal mucosal graft. Number two, directly buccal mucosal graft. And number three, I will like to do visual or visual picturectomy. VI. You tell me which you want to do. So Dr. Rathod, what you want to do?
I want to do then I will go for the first option SPC and then treat the infection and then BMG later on. Not only in BMG in active infection stage will have a higher failure rates. And
Prashant, what you want to
because
do?
of the two.
Sir, I would also like to first treat the infection, sir, by SPC drainage, sir. So when the environment becomes sterile there, then I would like to do still VIU for one chance of VIU will be better, sir.
Just because I'm telling you three options and I'm giving you some new idea, you don't have to say that. Think on your own and tell me. You may be right, but please tell me what you will like to do. I'm just giving you three options. If you want to do VIU, then I don't think that you have to do suprapubic and treat the infection, because after giving good under antibiotic cover, you can go ahead and do, as Dr. Gite has also said, you can do ureteroscopy and see the passage, or you can do VIU as the AUA guideline has said, once attempt you can do it, to the catheter and treat the infection. So I'm again giving you option. What is out of three, what you like to do?
I would like to go for VIU, sir, under antibiotic cover.
Okay. And Dr. Rathod, what you will like to do?
I want to put SPC and then treat the infection and then go for the surgery, sir. BMG, sir.
Okay. Gite sir. What they should answer in exam? Pankaj bhai.
Sir, I see no reason to do a SPC in this patient. Means let's not mix up pus cells with infection.
Sir, in this patient, if you are asking to me, I will go ahead with small scope scopy first, and as per the scopy finding, I will proceed. Number one. Number two, if the two strictures, if what is seen in that RUG, if it's same in the endoscopy, then I will go for BMG arthroplasty in spite of cutting here and there and excision. Two patches if required. If it is a single stitch, another option is one place non-transecting, one place small patch of BMG. And if it is a single stricture, non-transecting arthroplasty. VIU, if someone has told in this patient, that can be accepted as a primary first chance, guideline wise it is accepted, but practically the result of VIU is success rate is 14 to 45%. Overall success rate is 9%. That's what theoretic literature wise it is. So, and the luminal narrowing in this patient, it is a very dense stricture. So, until and otherwise there is a severe spongiofibrosis, then only there is a more luminal narrowing. It indirectly suggests the spongiofibrosis is more in that particular segment. So, option available, one distal only, non-transecting arthroplasty. Both stricture, one place non-transecting, one place BMG, or both dorsally cut the full segment and place the BMG. I mean for non-transecting means you have to, if necessary, if it is very narrowed, then you have to excise it and suture one wall and augment with another side if it is very narrowed or completely blocked at one place.
So I think you have got your answer. So both the thing is right. You can say that, sir, as per AU guideline, I will give one attempt of visual internal ureterotomy for this patient. If it is not successful, I will go for a buccal mucosal graft. Or as Dr. Gite said, you can directly go for a buccal mucosal graft, and you can answer as Dr. Gite said. Now only one question. Suppose if you decide.
As far as the discussion in the chat, in this patient, particularly this patient, I will go again with initially with the urodynamic study, not with RUG.
Okay. Fine.
So don't worry about the cost. The indication cannot be decided on the availability of investigation and amount of money the patient wants to pay. Here, urodynamic is indicated.
Yes, we have to follow the guidelines.
And if the urodynamic in first few seconds only, if you place the catheter and catheter is not going, means your urodynamic program is over and you have to go for RUG.
So you are not spending any money. Only for the infant feeding tube, nothing else. So don't worry about the money.
UDS is first. Clear cut answer.
Yes. So when such a uroflowmetry comes, young patient, you are suspecting voiding in this function, you must go for a urodynamic study, and you can go. See, we have done, this was done outside and he came to me. So, but otherwise I also might have done, RGU first. But as Dr. Gite and Maheshwari sir said, yes, we should go ahead with the urodynamic. Now the one question, before doing BMG, what are the important things you will look after? This is a practical thing I want to know, because I burned my finger. That's what I'm asking. You have done all the investigations, everything is fine. But before planning your buccal mucosal graft, what is most important now? Apart from that, I'm not talking of the stricture. Yes, one is the oral hygiene. And second?
and the comorbidities of the patient, sir. It has
No,
to be
everything
optimized.
is okay. Patient doesn't have now urine infection you have treated, you have no comorbidities. So you said oral hygiene. And second, Brijesh, show them the photograph.
Yes, sir. The patient has got a infection of the skin, sir, and fungal infection at local area has to be treated before attempting
Yes.
incision, sir.
See what happened. See what happened. These are the very important because once you take him for the surgery, you want to do buccal mucosal graft, and there is an active infection. Now what you will do? So
Sir,
this is a practical advice I want to give you. First, because
yes,
I
sir.
have burned my fingers by not initially examining the mouth, oral cavity, and when I went inside, I realized that there is a fibrosis. I could not take it properly, and like in this case, totally infected. So this practical answer. Okay, always see all these things. Gita sir, any advice?
सर ये नया वही पेशेंट है ना?
Yeah, yay patient. So
हाँ, so
actually we
already
did a VIU.
sir देखो doing a VIU, I am not against the VIU.
No. We were planning buccal mucosal graft. I'll tell you very frankly. But
Uh,
when we saw all these things, I said, I don't know how much, and his flow, and he had lots of problems clinically, and so he was willing for both the things. So we said, okay, we will go ahead with the VIU because that is also given as a guideline. But I agree with you. The first choice was buccal mucosal.
Yes, sir. If someone has asked given answer of VIU, that is okay in exam also.
Yeah. Accepted.
Nothing wrong in that.
Accepted. Yeah. Okay. Anything you want to add in stricture urethra? Any other questions from the students? Are there any questions? Fine. If there is nothing, then we stop here.
आपने जैसा बोला वैसा सर.
Okay, sir. Now the next when is the mock exam in Nadiad? What are the timing?
So 4 to 9, sir. Feb.
4 to 9.
Yes, sir.
So that is next Thursday, Tuesday. When it is?
Yes, sir. Next Tuesday, sir. Next Tuesday, whole week. Yes, sir.
Okay. No, because now shall we keep to next Tuesday our class or after that?
Sir, I appeal to all the students along with Campbell, please try to read a book by Indian urologist. First book by Indian urologist. It is available online. Because it is from our country only. It resolves majority problems which encounter in our areas. So majority your doubts will be get cleared in that book. That's what my feeling is.
Sir, what is the title of the book, sir?
Pankaj sir,
Textbook of male genetics.
Pankaj sir is editor is sitting in
clinical
front of
urology.
Sir.
Editor is sitting in front of you.
It is edited by someone called Pankaj Maheshwari. I don't know him.
You have really worked hard. Unbelievable. And I'm telling you, when I was a student and I was reading anatomy from Gray, okay, I used to read the last line and forget every other line. It was so difficult to understand. But then when the Indian authors, they started API and other Chaurasia and all, it became so easy to understand. The same way, I'm 100% sure your book is going to a boon to our Indian students. Definitely.
No, sir.
Great work. 1 year, 1.5 to 2 years you have worked
At
hard.
least out of the 160 clinical situations that are there, I would say at least more than 80% are quite up to the mark. So probably the second edition will be better than the first edition. But for the initial work, it has come off very well. So try to get hold of that book. Cipla company has decided to distribute it to all students.
Fantastic.
They may take time to distribute it to students, but that is one option, or you can buy it from CBS, which is not very expensive.
Good.
Congratulations.
Thank you.
Okay. So just write down on the group whether we should have a class on next Tuesday or not, and then we will decide accordingly. Okay?
Yes, sir.
Right, Pankaj bhai?
Surely, sir.
Yes,
Good
sir.
night,
Okay,
Pankaj
thank
sir,
you.
Gite sir, Gaurang sir.
Thank
Good
you, sir.
night to
Yes.
all students.
Good night, sir. Good.
And
night.
all the best to all the students. Okay?
All the best. Bye-bye.
Thank you, sir.
Ayush Chauhan, you are the host. Abhi, hello, Pushkar. Pushkar, you are host, huh?
Hello.
Pushkar. Gaurav.
Meeting over, sir.
Meeting is over. Just see the recording is there, huh? So ask Pushkar.
Sir, please make me host.
No, Pushkar is a host. Pushkar. So tell him to make you host.
Okay, sir.
Pushkar.
Hello.
Hello,
Pushkar, sir.
Pushkar.
One second, sir.
You have a number, his number?
I call him, sir.
Please. I want this recording proper. Huh?
Okay, sir.
Gaurav,
Ask, just
you asked,
yes, sir.
he's not picking up.
Picking sir call my. He making me host.
He's making you host. Huh?
Yeah.
Okay. Just see that recording is proper, huh?
Yes, sure, sir.
You know now how to make. Just don't leave it.
I know,
End the
sir.
meeting.
Yeah.
You know that, na?
Yes, sir.
Yeah. Okay.
Okay, sir.
So I leave the meeting.
No, okay, sir.
Should I leave the meeting?